I truly believe that any sports therapist needs to be an orthopedic therapist first. So to me, because I think our Ortho Academy has done such a great job of emphasizing manual therapy interventions and really looking at the whole body, especially to obtain something like the OCS, I consider myself an orthopedic therapist first and foremost. And then I think you can add on the specialties of whatever your sport that you like to treat is.
Hello, and welcome to the Academy of Orthopedic Physical Therapy's podcast, Ortho Static. I am Ben Braxley. I'm a member of the Academy's leadership team on the podcast, and you're about to listen to a conversation that I had today with Dr. Amanda Blackmon. Mandy is a co-founder and owner of Atlanta Dance Medicine. She also serves on the international board for the IADMS, International Association for Dance Medicine and Science. And she is an educator with myopain seminars on dry needling. So we have a wide-ranging conversation on dry needling, the treatment of dancers, specifically dancers with hypermobility syndromes, and even just a little flavor for international education and practice. So we have a great conversation. I hope that you will enjoy it. Thank you for listening to Ortho Static. All right. Hello and welcome to the Academy of Orthopedic Physical Therapy's podcast, Ortho Static. I am Ben Braxley, and I'm here today with Dr. Amanda Blackmon. I am a neuro PT doing an orthopedic podcast, but I'm based in Atlanta, Georgia, where I practice clinically at the Shepherd Center on spinal cord injury units. And I'm also a program coordinator for Emory's new Physical Therapy and Movement Science Center. I also serve APTA Georgia as president-elect, and I'm on the leadership team for the Academy's podcast, and that's why I'm here today. And I'm here today with Dr. Amanda Blackmon, the co-founder and owner of Atlanta Dance Medicine. She sits on the board of the International Association for Dance Medicine and Science. And you're also a lead instructor for myopain seminars in dry needling, heading up the program for occupational therapists and certified hand therapists. Did I get that right?
Yeah.
Excellent. Well, I'm so happy that you're here today, and I look forward to our conversation where we're going to talk about your path to teaching dry needling, to dance medicine, and kind of overlaid on top of that is this subpopulation of individuals with hypermobility syndrome in dance. How's that sound?
Perfect.
Excellent. Well, why don't we start with that? Tell us about your path to teaching dry needling.
Awesome. Well, I, interestingly enough, made it through an entire doctorate of physical therapy program without ever hearing the terms trigger point or dry needling, which was interesting. And I was sitting in a continuing ed class with one of my mentors, one of your mentors, Joe Donnelly, and the entire continuing ed class was about trigger point referral and myofascial pain. And it was like a light bulb went off in my head. It wasn't a component of my clinical diagnostic hypotheses that I was considering in my patients. And I really felt like it was the thing I was missing in a lot of my patients, but also explained a lot of the pain that I've had in my life. So I went to Joe and I said, how do I learn more about this? And he's the one who introduced me to myopain seminars, and Jan Domerholt, who I'm super grateful for those two men for being mentors in my clinical path. So I went through myopain's training back in 2009 and 2010. Back then it was 5 long weekends, 17 days of trigger point treatment. That was dry needling was part of that, but we also treated manually, and we talked about more of the overall management of patients with chronic and persistent pain. From there, Jan invited me to be an assistant instructor with myopain, probably 2013. And then I got trained as a lead instructor and started teaching for the company in 2015. I've taken off from there. I get to travel around the country a lot. I usually teach on average between 12 and 14 weekends a year. So I get to meet colleagues all over the United States, and it's really become a huge part of my profession and the biggest hat I wear, I guess, is being a teacher for myopain. And then just recently worked with Jan to kind of take over teaching the occupational therapist and certified hand therapist. We do a condensed course for them that is more focused on upper extremity and spine, less lower extremity. But that's been really fun to work interdisciplinary fashion with our OT colleagues because they're a unique group and I just really enjoy teaching them.
Yeah, I can imagine. I've done some education for other groups than just PTs, but every time you bring in more perspectives, you just get differences of opinion and difference of philosophy and approach to patient management. So I can see how that would be interesting. Yeah, CHDs are unique too, in that they kind of bridge both of the PT and OT worlds. So I can
Sure.
imagine that being interesting and rewarding for
Yeah.
you.
And I'm learning a lot
So
because as a dance medicine therapist, I'm more lower extremity and spine focused, and I'm learning about, syndromes and surgical procedures and things that I'm just not aware of. So it's been really fun.
yeah, and this being an orthopedic physical therapy, podcast, I'm curious, kind of what's your perspective on where trigger point dry needling fits into kind of the toolbox of orthopedic clinicians? Is it the number one tool? Is it one of many tools, or does that depend on the population?
I think it is one of many tools, and I actually get a bit concerned that clinicians, if they learn this tool too early in their career, may actually overutilize it or throw other tools out of their toolbox because it really should be used in conjunction with all the other tools we already have. I think there is a tendency to become over reliant on it from both the clinician and the patient perspective. And I think if you don't use dry needling more as sort of a reset button, but then following up with neuromuscular re-ed, therapeutic exercise, I call it the software upgrade, then we really do chance falling into that over reliance on manual therapy and more of a passive intervention. But I
Yeah,
also think there's more opportunity for using dry needling in a more acute population. We're starting to see it more, acute sports injury and things like that. Whereas previously, I think it was used more for that chronic and persistent pain. So I think there's a spectrum of how it's being used.
excellent. Yeah. And being a neuro PT in this ortho world, I mean, it's even being used for spasticity management in populations that tolerate it, whether in brain injury side, spinal cord injury side. So I think it is certainly has many applications. I am not dry needling certified,
You will be
but
at some
certainly,
point.
yes, I should. I should. I know some good educators, so I know where I can go for more info. And credit where credit is due. Myopane is a relatively was an early educator of this in the United States. Do I have that right?
Correct. Jan brought dry needling here in, I believe, the late 90s and was the first, he's Dutch, so he brought it to the United States. Myopane was the first and only dry needling education company for about 10 years. And a
Okay.
lot of other practitioners got trained under Myopane and then took that material and have made it their own, which is great. There's a lot of other good dry needling education out there, but I am proud to work for Myopane, having been sort of on the forefront of that education. And I do think that there's a difference in teaching a clinician how to needle versus teaching a clinician how to manage a patient population of chronic and persistent pain or how to manage an acute diagnosis with dry needling as part of that toolbox. And I'd like to think
You
that
give
we're doing a really good job of that.
Absolutely, absolutely. And you give me a great segue in speaking about special populations because in addition to wearing your largest hat of an educator in the needling space, dance medicine has been a part of your career for a very long time. And I'd love to hear a little bit of your journey, both personally with dance and then getting to where you are now because you wear maybe not your largest hat, but many hats within the dance medicine field. So share some of that with our listeners.
So I was a dancer through high school and then dabbled a little bit in college, but not a ton. I decided I was going to be a PT when I was 14. So I was always headed toward PT school and was never really good enough to go down the professional dance path. But when I was in college and then even in grad school, I really missed the dance world and the performing arts world. I originally had planned on being a neuro PT. I don't even know if you know that, Ben. I was really thinking I would be the one working at Shepherd because the Shepherd Center is what made me want to be a PT. But I absolutely miss dance in the performing arts world. So right after graduating Emory, sort of started heading down that path and got my Pilates certification, started taking continuing ed courses in dance medicine, really got plugged into what is a very unique community. It's interdisciplinary and international. And most of the dance medicine PTs in the world, I would say, actually know each other. So it's been a fun little group to be a part of. And I started treating Atlanta Ballet about 10 years ago. This is our 10th season. We just closed our season yesterday. And then started
Congratulations.
dance medicine with my business partner, Emma, in 2020. And we have 3 locations that mostly treat adolescent dancers around the Atlanta metro area, but also professional dancers, dance moms, and everything else. So we run the spectrum from that little bitty 10-year-old ballet dancer all the way up to the professional dancer, all the way up to the retired and aging dancer.
Nice. Yeah. What types of so across that continuum, what types of injuries do you see most often that linger, I guess, because chronic pain and management of individuals dealing with chronic pain is something you touched on earlier.
Yeah, so I would say a huge majority of dancers are on the hypermobility spectrum. So not necessarily Ehlers-Danlos syndrome or full-blown, connective tissue disease, but on the spectrum in that they have some degree of hypermobility, which to me means if they do get injured, often that injury lingers a little bit longer than maybe your average sports or athletic injury. In general, in dancers, we're seeing mostly lower extremity, but dance has evolved so much through the years, especially with shows like So You Think You Can Dance and Dancing with the Stars. Um, you have women partnering women, you have women partnering men, you have women lifting, you have a lot more floor work and tricks. So I would say what used to be a primarily lower extremity injury activity has now kind of run the gamut, and we're seeing anything and everything you can think of: wrists, elbows, shoulders, spine, all the things. And in younger and younger dancers, unfortunately, because of the tricks and the competitive nature, um, things have gotten a little more significant in the
I
dance
can
world.
imagine. So in terms of hypermobility, do you think that dance selects for individuals with hypermobility, or do you think there's something about dance that leads to hypermobility over the course of a career or a lifetime?
It's a
What's your
huge
philosophy there?
debate in our world. Is it nature versus nurture? And I think it's probably a little bit of both. I think that kiddos who are a bit hypermobile tend to be very successful in dance. Therefore, it's self-selecting because they're good at it. But if you're too far on the hypermobility spectrum, you're not going to make it because you're going to be chronically injured all the time. So I think there's sort of that Goldilocks space of just mobile enough to be successful, but then maintain control over it. The other thing we see in the hypermobility demographic is that many of them are often protected by their sport or activity. And it's not until they stop doing their sport or activity that some of those sequela of hypermobility start to show up. Like, say it's the high schooler who was dancing 20 hours a week, but now she goes to college and all of a sudden starts having chronic pain. Or there's some trauma, little t, big T trauma, whether that's a physical trauma or an emotional trauma, that sort of uncovers some of those hypermobility symptoms that maybe the dancer hadn't had before.
So it sounds like it's one thing to be hypermobile and strong, and another thing entirely to be hypermobile and then, have a big change in your conditioning load. Is that,
Absolutely. Yep. Tends to
yeah,
be a major trigger.
can imagine. Can imagine. So I guess being a total novice in the dance world, is it somehow seasonal, where with early single sport specialization we can kind of predict to some degree the sports and the cycle. What do you see with dancers?
Yeah, unfortunately, dancers don't tend to have a season. It's one of the major problems is that the dance medicine world has not kept up with the sports medicine world, as well, as far as periodization and tapering training and ramping up training. And we do see a click up around, say, December when it's Nutcracker season. We'll see a tick up in injuries, but then a lot, and maybe in May, like right now, we are super busy with kids doing spring recitals, spring shows, but then also in final exams, very similar to December. But then we have kids going away for 5 and 6 week summer intensives where they're dancing maybe 6 to 8 hours a day, 5 to 6 days a week for a good portion of the summer, and their bodies aren't necessarily ready for that, nor is it necessarily good for a 15-year-old to be dancing 30, 40 hours a week. So we see a huge spike there. There's just unfortunately not a great season in the dance world. There are upticks, but it's sort of on without much rest throughout the entire calendar year, depending on what you're talking about.
Yeah, I mean, talking about training load and athlete protection, that's a pretty astounding thing to hear said. Like if we were training other athletes that way, a lot of years would peak up and we'd kind of question whether or not that's necessarily the best way to go about it. But you can see how some people might feel differently about dance, and that's probably an assumption that shouldn't be made.
Well, and dance is very rooted in the history and the tradition, right? Many dancers would consider themselves more artists rather than athletes. So
Mm,
getting that buy-in into the sports medicine literature and the sports medicine research can be difficult, especially when you're talking about maybe a older demographic of dance teacher who they did it this way, so they're going to teach it this way, more that
right.
traditional. But that is one of the things that IADMS is really working to change, which is why it's so nice that it's A, international, and B, interdisciplinary, because you have the medical side, and then you have the science side that's more the researchers, but we also have members who are dance professors and dance teachers and more on the studio side of dance. So that's kind of what we're trying to bridge is the art side with the science side.
That's fascinating. And again, an organization that wasn't on my radar at all. So you say the acronym IADMS, but it's the International Association for Dance Medicine and Science.
Yes.
And so how did you end up on the board? What was your
Oh,
path
how did
there?
I end up on the board? Because I have trouble saying no, Ben.
I
No,
can't relate to that at all. Yeah.
I was involved in leadership for POSIG, Performing Arts Special Interest Group, through the Academy of Orthopedics in APTA. And through getting started with POSIG, you get plugged into other dance medicine and performing arts medicine organizations. So I got involved with IADMS fairly early on in my career. And then just going to conferences. We are outside North America every other year, which is really fun. It's been a great opportunity for travel and to see the world. And because we're a fairly small organization, you really just get to know people and colleagues very, very well. So when the Nancy Cadles and the Kathleen Davenports and the Matthew Griersons, all three physicians, come to you and say, we think it's time for you to take a leadership role in this organization, it's really difficult to tell those people no.
I can imagine. I can imagine.
The other
And
cool thing I will put a plug in for IADMS is that we have a separate, it's not separate. We have another silo within IADMS. Our motto is health for dancers and dance for health. So we have a whole subsection that of members who are using dance as an intervention. And as you know, it's huge for the Parkinson's population and some other more neurological diagnoses. So that's the subset that we've added on probably in the past 6 years. That's pretty cool looking at more of that neurological population.
that's fantastic. Yeah, I always get concerned when our silos, and APTA is a phenomenal organization, but it can be hard to figure out where something like dance fits. Is it
Mhm.
orthopedics? Is it sports? It's obviously both, but it's going to have neuro. It's going to have, a multitude, pediatrics. Concussion is another good example. Many of these things are going to impact across the spectrum. So, putting you on the spot, do you consider yourself more an orthopedic clinician, a sports medicine clinician? Like, when do you fall into more one bucket or the other? Or do you think the bucket should be thrown out and we should look at it differently?
I wish we could throw out the bucket, but I understand the reasons for the silos. I truly believe that any sports therapist needs to be an orthopedic therapist first. So to me, because I think our Ortho Academy has done such a great job of emphasizing manual therapy interventions and really looking at the whole body, especially to obtain something like the OCS, I consider myself an orthopedic therapist first and foremost. And then I think you can add on the specialties of whatever your sport that you like to treat is. So it may not be a very popular opinion, but I'm going to say it. I almost think an OCS should be a prerequisite for an SCS.
Oh, interesting, interesting. We'll have to look for the comments on this and
Yeah.
see some different opinions.
I've
Although
had that argument with a former president of the sports section, and I'm a member of both. But that's my opinion.
that's great, and I'm sure you're not alone in that opinion. And I can see, good arguments for and against this approach, depending on what kind of brings people into the profession and where they see themselves growing. So yeah, I love the academies too. As someone who's moved around a fair amount, it gives us a great way to stay involved and to serve without necessarily being geographically linked. But there is that risk of being kind of cognitively linked a little bit too narrowly. So being members of multiple academies, as you are and as I am, is a great way to kind of cross-pollinate or get out and see more and see the connections between more different areas of practice and
Absolutely.
research and
I'm
education.
also a member of the pelvic floor group, and there's a lot of crossover there with treating all athletes, but specifically dancers and patients with chronic pain. So I think there's just great opportunity for, as you say, cross pollination.
Yeah, yeah, it's my good visual for that. I always enjoy that kind of reference. So, well, that's great. I'm curious, too, as we talk about IADMS and kind of the international travel aspect. Have you done outside of dance medicine? Have you done any travel for physical therapy education, whether as a student or as a teacher? Can you tell us about
Yeah,
that?
I got a great opportunity back in 2018 because of my OCS. So again, I will plug the Orthopedic Academy. I got to travel under the Jackson clinics to Kenya and spend 2 weeks in Nairobi mentoring and teaching physical therapists there at three different hospitals, but also one on one and then in the classroom. And it is probably one of the most significant things I've done as a physical therapist. It was incredibly rewarding. I know Jackson Clinic has relaunched that program and they're looking for clinicians with their OCS that are willing to go and teach for 2 weeks in the classroom and outside the classroom. And I highly encourage our OCS members to look into that because there's just nothing better. It was absolutely fantastic. And actually, they've opened it up to other specialties as well, but it started as OCS. I think now they're looking for cardiopulm, pelvic floor, and even neurospecialists to go and do little segments of that education. And I think the plan is to expand it even outside Kenya into other parts of the southern part of Africa.
That's phenomenal. Great experience to have, and great way to give to other communities around the world in need. So much respect to the clinic and to you and other clinicians like you who take that opportunity. Out of curiosity, was that interdisciplinary as well, or is that exclusively a group of PTs traveling?
When I went, it was just PTs, and typically they only send one or two PTs at a time. They're actually working with PTs who have already graduated their entry level physical therapy education program and are working in what we might consider more of a residency,
Okay,
but maybe not to the same level that our residents and fellows here in the States are working at. We're working a lot on um, clinical reasoning and regional interdependence and putting the pieces more together. Again, it's been 6 years since I've been. So I'm sure they've evolved. And I know COVID was a huge hit to that program, but mostly in the physical therapy silo.
well, hopefully it's an opportunity. I've heard about more and more programs that did have to kind of close their doors for a period of time, but now with some distance, they're looking at how to innovate and build on what they previously had done in the lead up to COVID, and hopefully you'll see more great opportunities like that. So I feel like we're kind of coming to the end of the conversation, so I have one more kind of planned question for you. Given the amount of interdisciplinary work you do and the different areas that we've touched on today, I wanted to ask what your three favorite tools or resources might be, whether it's inside of APTA or outside, if people want to learn more about the things that you talked about today. So give us three resources for takeaway.
I can do that. I would say Myopain seminars is going to be one. We've done such a good job as a faculty of putting resources out there, multiple blogs, multiple, educational components that are just on the website that are absolutely fantastic. Second, I would say IADMS for anybody that wants to learn more about dance medicine, health for dancers, or dance for health. IADMS is a great resource that puts out a lot of free resources and educational materials. And then we have both our annual international conference, but we also have regional conferences. So there's one coming up in Mexico City here this summer. And
Very
then
cool.
third is actually going to be a book. It came out in May of 2020. It's called Disjointed. It is an interdisciplinary compilation on resources for patients who are on the hypermobility spectrum. And it is a book that I recommend to every single patient I come across with hypermobility or Ehlers-Danlos syndrome. But I also think it's a fantastic resource for clinicians as far as putting the pieces together of managing the hypermobile patient, because they don't always realize how multisystemic their symptoms might be and that all of those symptoms may be connected. So I think it can be a very validating tool for patients as far as, oh, I'm not crazy. These things all have a common thread, but also for clinicians in trying to put together your team to help these patients get the help and treatment that they need.
Awesome. Well, three great resources and a great conversation today. So thank you so much. This has been another episode of the Academy of Orthopedic Physical Therapy's Ortho Static podcast. Thank you, Dr. Blackman.
Thanks, Ben. Good to see you.